Hi, good evening, everyone. A very warm welcome from Smiledge Dental Education to all the participants joining us today. It's a pleasure to come together for today's webinar on the 2mm margin understanding, the biological width for long-term success. On behalf of Smiledge Dental Education, I, Dr. Priya Sharma, co-founder Smiledge Dental Education, thank you all for joining us today for this educational webinar. We are truly delighted to see such an enthusiastic participation from dental professionals across the country. Our vision is to be the leading center of dental excellence, and our mission is to deliver comprehensive hands-on training, fostering a mentorship-driven environment, equipping every participant with precision artistry and integrity, and creating a bridge between academic knowledge and clinical expertise. We believe that continuing dental education should not just be a theory topic, but it should be about the real chair-side solutions that improve patient outcomes. It gives me immense pleasure to introduce a speaker for the day, Dr. Arvind Nagaraj, a highly accomplished periodontist and implantologist. Born and raised in Muscat, Dr. Arvind's journey in dentistry took shape at A.B. Shetty Memorial Institute of Dental Sciences, Mangalore, and has since grown across some of the Bangalore's most respected dental centers, including Ridgetop Dental International, Smiledge Dental, and Clove Dental, before he founded his own practice, Akoya Dental. A recipient of the national level award, My First MIS Case, from MIS Implants, Dentsply Sirona, Dr. Arvind is known for his meticulous approach to dental implants, gum health, and heart and soft tissue reconstruction, combining precision with a deeply personalized style of care. Beyond the clinic and classroom, you'll find him on the football field or cricket match, bringing the same energy, teamwork, and balance that defines his professional life. We welcome you, Dr. Arvind. Before I begin, a quick note for all the participants. Please keep your microphones on mute during the session. You may post your questions in the chat box and Q&A section, and we will take them up during the Q&A segment. The feedback form link will be live and shared on the chat box. Also, we are going live on YouTube, so the link of the same will be shared on the chat box. And to stay updated with the upcoming dental webinars, clinical events, and educational content, please do follow us with Smiledge Dental Academy, and the various links of the same I will be sharing on the chat box shortly. So without any further delay, I would like to invite Dr. Arvind to take over the session and share his valuable insights with us. Over to you, Doctor.
Thank you so much, Doctor, for that very generous but very accurate introduction. We're going to get started now straight away. Good evening, ladies and gentlemen. Today, what we're going to talk about is the 2mm margin, something that is often neglected, something that's very critical. Okay, so let's start with something very simple. How many of us here have faced this in our clinical practice? You have the perfect crown of veneer preparation. You've managed the perfect shade match. You've recorded all the detail you need in your impression or scan, whichever you're using. You've reached out to the fancy lab off of Instagram. You waited 3 days, you waited 4 days. In your hands, you have a beautiful prosthesis. You've read about it. You've followed the ideal cementation protocol. You've done it all. You've skipped no steps. You've asked the patient to pick up a water flosser. You are extremely proud of yourself when you look at that cementation or the cemented crown. You sit back maybe that evening, you think about maybe I'm charging a little bit too little for my aesthetic work. You cut 3 months later, your patient is scheduled for a review. You're super excited. But the moment the patient sits in your chair and you have the patient smile, you see that the papilla is swollen, you see that the gums are puffy. You pick up the probe, you touch, and you see they bleed. You're upset, you're disappointed, you don't click photographs that day, you do a round of scaling, you send the patient back, you say, come back after a week, let's see. And today we're going to talk about why that probably happened, what we should look for, and how we can avoid this in our day-to-day practice. Like I mentioned, the 2mm that we're going to talk about today, they're probably the most neglected, but the most critical in our clinical dentistry, clinical practice. So what we're going to be talking about is the biological width. This is something that we've all studied. Historically, it's been called the biological width. However, as time has progressed, as of 2017, they have now changed the terminology. Now it's called supracrestal tissue attachment. What this essentially is a dimension of soft tissue that is attached to the portion of the tooth coronal to the crest of your alveolar bone. So essentially, as you can see in the diagram, it comprises of your sulcular epithelium, the junctional epithelium, and the connective tissue. This entire apparatus that we have is essentially the physical innate seal or barrier that your body has set up to protect your teeth and you from the oral environment. Now, having undergone various multiple cadaver studies and all of that, they have come to this measurement, a mean measurement of about 0.69 millimeters of the sulcus depth, an epithelial attachment of 0.97 millimeters, and a connective tissue measurement of 1.07 millimeters. You add all of that together, you're looking at uh, a biological width of 2 millimeters, followed by the sulcus depth of about 1 millimeter. So now this is how the biological width sets itself up around natural teeth. I'm sure that a lot of us here practice and restore dental implants. The biological width around teeth and around implants are very different, both structurally and also at a histopath level. The primary difference here comes from the fact that the fibers on your natural teeth are attached perpendicular to the root of the tooth. So what happens is they form a more rigid barrier. In the case of implants, what you have is you have the fibers that are running parallel along the surface of the implant that makes it very weak and much more fragile. We'll circle back to all of this later, but what we want to understand here and what we want to change here is that there is a lot of importance being given to the perio-restorative interface in today's restorative dentistry. However, a lot of us are not able to completely grasp or understand this concept of biological width, and by extension, we're not able to put this across into our daily clinical practice. So, the series of webinars that we're trying to plan henceforth are to help understand and how we can incorporate periodontia into our daily clinical practice. So, now, when we talk about restorations, the primary thing that comes in is your restoration margin. So now we broadly divide them into supragingival, equigingival, and subgingival restorations. From a periodontal standpoint, supragingival and equigingival margins are well tolerated. Supragingival margin is very simple. It's above the crest. It's above the gingival margin. It's easy to maintain. It's easy to take care of. But of course, they're aesthetically extremely poor to look at. The equigingival margins, in spite of it being at the gingival margin, owing to how well labs are equipped in today's day and age, you have an extremely polished surface at the margin. So now it limits the amount of plaque accumulation and such. Now, when we are doing anterior restoration, we're doing anterior aesthetic work, there is a need to place our restorative margin subgingivally. So when we do these subgingival margins, often what happens is the margin is pushed too far below the crest, the height of the gingival margin, and this violates what we call the biological width, the 2 millimeters that we talked about. So now the 2 millimeters that we needed between the crest of the bone and the gingival margin we've destroyed. So what happens when this margin is less than 2 millimeters? When we violate this space, our body reacts. And how does the body react? We call it the angry red color. It's essentially a persistent redness that is always present around the margin of the gingival margins. However, well you brush, you water floss, you've done scalings repeatedly, you're using the normal floss, but however, there is a chronic inflammation that is constantly there. Patient complains of a discomfort sometimes, the gums bleed profusely when you just touch them. This is essentially your body trying to tell you that, boss, there's something wrong. And your body is trying to distance the alveolar crest, is trying to distance itself from the irritation that is being caused by the restoration margin. Now that in our Indian population, in your day-to-day clinical practice, you will see that a lot of your anterior restorations are in a situation where you cannot be you cannot be placing your margin straight away without having to do something to establish that biological width. So what we're going to talk about now is how do you calculate how much space you have between the margin and the alveolar crest. So one very easy way to do this is with, of course, I'm sure all of our chairside radiographs, all of us have an RVG or we have our IOPs. So we have these 2D images. CBCTs, of course, can be used. They are good, but they aren't extremely reliable when it comes to bone that is extremely thin, or if there are any metal restorations. The ideal and the gold standard to evaluate biological width is what we call bone sounding. So, how do you go about bone sounding? First, ensure that there is profound anesthesia. You use your perio probe. What we need is very accurate probing, right from the gingival margin through the attachment, right through the rest of the bone. You anesthetize, you probe, and you evaluate. What are we evaluating here? We are looking at how much of the probe has gone into the pocket. We are aiming for 3 millimeters. 3 millimeters is what we are looking for. It is 2 millimeters that is accounted for the biological width, and 1 millimeter. Now, most of your restorations, say tomorrow you have an anterior restoration, you try this, you're going to see that you don't have 3 millimeters of height between the gingival margin and alveolar crest. How do you fix this? So now, when we look at how to fix this, we are broadly looking at two methods of treatment. One is a surgical method to treatment. One is a non-surgical method, which is essentially with the use of we reach out to our orthodontist friends and they help us with non-surgical fixing of the biological. Talking about how to go about fixing this from the periodontist perspective. So what we're looking at is in the surgical section, we are looking at a gingivectomy, which is soft tissue. You're adjusting the soft tissue. You're looking at raising flaps with or without ortho surgery, or we're looking at opically moving the entire flap to be able to establish the 2 millimeters from the crest. Gingivectomies, we can use a normal BP, a 15 number blade along with the BP handle. We can use diode lasers. We can use electrocautery. There has also been documentation of chemicals such as 5% paraformaldehyde that has been used. However, this is not practiced very often, primarily because it's very difficult to control the depth of action. There are chemical burns that are forming, and you also have situations where the healing is extremely slow. Now we'll talk about each of these, the surgical correction, how to go about each of these, what the indications are, how to go about, how to choose what method of gingivectomy or what method of surgical correction to follow, and we'll run through it how the steps go for this one by one. So the first one that we're looking at is the conventional external bevel gingivectomy. So this is a soft tissue only procedure. You've done your bone sounding. You've seen that um, you have 3 millimeter. You have a little bit more than the 3 millimeter distance. You have an adequate band of attached gingiva. So what we do here is we use something that's called a pocket marker. If you don't have a pocket marker in your clinic, you can use a very sharp probe. So what we do here is once anesthesia is administered, you make small bleeding points along the margin where you want the incision to be made. As you can see in the first, on the left, the top left of your screen, small pinpoint bleeding points are made. Once we are happy with the margin that has the preferred the incision line, we go ahead with a very simple 45-degree incision that is made at a point that is apical to the base of the pocket, and you move in a coronal direction towards the surface of the tooth. So how you can go about this is either in a continuous fashion. In the initial days, if it's difficult to do it in a continuous fashion, you can also do it as a interrupted. You do one and then you go to the next tooth and then the next tooth. So this is a very simple process, but ensure that you have adequate keratinized tissue and the bone crest is at a level that is favorable. This is a purely soft tissue procedure that has to be done. Here, what happens is the healing that happens post this procedure is by secondary intention. So the patient can experience some amount of discomfort post the procedure. So these are small things that you can prepare the patient for once it's done. It's a fairly easy process to do, very simple, but this is not something that you will be able to do very often. Next, we come to the internal bevel, internal bevel flap that has to be raised. Here, we do have an adequate amount of keratinized tissue, but there has to be a small procedure done to the alveolar bone as well. So what we do here is, as you can see, first we make an internal bevel incision. An internal bevel incision is essentially an incision that is directed towards the crest of the bone. So what we do here is, once anesthesia is administered, we make the first step is to make an incision that goes straight to the crest of the bone. These are cases where there is adequate keratinized tissue. However, the bone is at a level that is too close to where we want our margin, the restoration margin to be. What we have to do is we need to move the bone away 3 millimeters from where we want our margin to sit. So the first step, like you can see here, is we go ahead, we make that incision. The next step is we raise a flap. Once the flap is raised, we make a sulcular incision or a crevicular incision, however you call it. Once that is done, you make a horizontal incision. The band of tissue that is formed is taken out with a curette, either with a curette or in most cases, it comes out by itself. Once that is done, make sure that you've removed any granulation tissue that might be present in the area. Once the granulation tissue has completely been cleared out, we use we use a burr, and then we move the gingival alveolar crest to a level that is 3 millimeters below the restoration margin that is planned. Once we have done this, we place simple interrupted sutures, and once sutures are placed, the healing happens by primary intention. So usually there is it's very post-operative discomfort is very minimal. And once this is done, you have your adequate biological width, you've moved the bone away, and then you can establish your subgingival margin wherever you wish to place it. This is what you will be doing more often. Um, this is what you will be doing most often in your clinical practice. Again, like just to a quick recap of what we've discussed in case there are any questions, the external bevel gingivectomy or the internal bevel flap that is raised. So one is a purely soft tissue procedure. The one where you have to raise a flap is where you have to move the bone. Like I said, the external bevel is directed towards the crown. You make an incision, you take out the extra tissue that is there. Post-op discomfort, like I said, is slightly higher, and the healing is by secondary intention. Now, when we come to the internal bevel, to quickly run you through the steps again, we make an incision straight to the crest of the bone. After that, we raise a flap, we make a sulcular incision, we make a horizontal incision, and then we take out the band of tissue that is there. We mark where we want our margin to be, we trim off the bone accordingly, and then we place the sutures. We place the sutures and close the flap once we are done with our cautious remodeling. All right. So both these cases that we have discussed, these are cases where we have adequate attached gingiva. Now, what we're going to do now is, what do you do when you don't have attached gingiva? Here, what we have to do is we need to move the flap up. So we cannot afford to lose the band of attached gingiva that is there. However, we don't have adequate amount of um, height to be able to place a subgingival margin without affecting the rest of the bone. What we do here is we start with the internal bevel incision like we did in the previous case. In this case, we need to use vertical incisions to mobilize the entire flap. The vertical incisions stretch right up to the beyond the mucogingival line. A full thickness flap is raised. Once the flap is raised, like you can see in the images, once the flap is raised, a handpiece is used. We trim, we remodel the bone. Once the bone has been moved to a position that is at least 3 millimeters away from where we plan to place the restorative margin, we clear out any granulation tissue that might be present, and then we suture the flap in a slightly apical position to where it was initially. So this is done with simple sling sutures or a vertical mattress sutures, and then you have to suture the incision line. So this is done in cases where, say you have, especially in the anterior area where you cannot afford to lose any attached tissue, say you have a fractured tooth, is very difficult to restore, and you can't establish a ferrule if you're not able to move the flap up. All right, so this is in cases that we don't have adequate tissue. Now what we come to is, so this covers the surgical side of things, like we discussed. The first step is a simple gingivectomy, either with a blade, with your laser, or with your cautery. The second one is the internal bevel incision, where internal bevel incision, you raise a flap, trim off the bone, reposition the flap where you want to place it. Then is the apically positioned flap, where the entire gingival apparatus is moved up to compensate for the lack of attached gingiva. That covers the surgical side of how to treat, how to go about having situations where there is a where there is a violation of biological width. Now we look at the non-surgical side, which is where you have to do orthodontic extrusion, either with slow forces, rapid forces, and now there are people that are also using magnets to do this extrusion. So your slow orthodontic extrusion is also called forced eruption. Here, what is done is very light, very mild forces, but continuous forces are used. They are typically under 30 grams of force. So what happens here is, as the tooth extrudes, the supporting bone and the gums move coronally with the tooth. So usually, what happens after the tooth is extruded with the entire apparatus around is that you will have to do some small minor periodontal corrections to establish your final aesthetics. This usually takes about 4 to 6 weeks of extrusion, followed by around 8 to 12 weeks of retention in that position that is there. In your rapid orthodontic extrusion, the forces are much higher. There are over 50 grams of force. And what happens here is the tissues around the tooth cannot adapt quickly enough to how quickly the tooth is moving. So here there is a requirement that every week you do a pericision or a fibrotomy around the tooth. You sever all the PDL fibers around the tooth to prevent the bone and the gums from following. So the tooth just moves. It happens in a much faster fashion, and the surrounding tissue is left where it is. This usually takes about 3 to 4 weeks, and then the stabilization and the retention period for this is around the same amount of time. A more new method of doing this is now with magnets. So first, the tooth that needs to be extruded is RC treated. Then a small cylindrical magnet is bonded onto the remaining root or tooth structure that is there. And then the patient is given either a splint or an RPD with a corresponding magnet. And then with the magnetic forces, the tooth starts to move down. However, this is a very expensive process, and also what happens here is there is a constant need for you to keep trimming out the splint and the RPD to keep moving the magnet into the position where you want to move the tooth into. Like we discussed, we circle back to the biological with considerations around your dental implants. So here, like I said, here the fibers are running parallel to the surface of the implant. So what happens here is, because of this, the connection that is formed there is extremely weak. The earlier implants, as you can see in the image on the left, in the earlier implants, the width of the abutment and the width of the implant were similar. So what was done is there was something that was called a platform switch that was done, which is essentially the platform onto which the abutment is seated was modified in a way that the width of the abutment was shorter. The abutment which is the fixture that goes onto the implant, is narrower than the platform of the implant. So what happens here is, because of this, the soft tissue would go and adapt onto the surface of the exposed implant shoulder in a horizontal fashion instead of being vertical. And as the tissue moved horizontally onto the neck of the implant, it became a more stable connection. So in the earlier implants that were platform matched, as you would call them, the body as you can see on the right side of this image, the body would resorb about a millimeter to a millimeter and a half of bone to make room for the soft tissue to adapt. Which is why in the platform matched implants, you would see a lot of crestal bone loss. So to compensate for this, what they've done is they have incorporated a platform switch. So the rate at which the crestal bone resorption happens is reduced. Essentially, the idea here is to create a platform onto which the fibers can sit horizontally. This is one very important, when you choose the implants that you use, it's very important that you choose implants that most of them are platform switch now, but just ensure that you are using implants that practice this. And another very important rule that we need to follow is called the 3B 2D rule. The 3-2 formula is essentially a prosthodontic guideline to where your implant should be positioned to ensure that your prosthesis is a long-term stable prosthesis in terms of function and stability. Right. Now, your patient does not care. The patient has no use of a screw in the bone, right? The patient needs a tooth on top of it that is functional and that is aesthetically pleasing. So the 3-2 rule is essentially when you place your implant, the implant should be placed 3 mm apical to where you want your gingival zenith to form. This 3 millimeter gap that you have between where you want the gingival zenith to form and the platform of your implant, which is the crest of the top of the neck of your implant, this is what will allow you to create a natural emergence profile. The 2D rule is essentially you need to have 2 millimeters of bone on the buccal side of the implant to ensure that the tissue around it is absolutely. Now, to quickly wrap up here, a very important thing is do not rush your impressions once you have done any form of crown lengthening. If you place your in final restorations too early, you don't give the soft tissue enough time to heal and to stabilize at a level. So what happens is you will see that the soft tissue margin will migrate as if you've gone in and placed your restorations too early. So the ideal waiting period, as the textbooks would say, would be 6 to 12 weeks or post gingival or any crown lengthening procedure. In the aesthetic zone, it's always better to wait for 3 to 6 months. Make sure that you're giving very well contoured temporaries during healing and maturation. And in today's day and age, it's very difficult to have a clinical practice where you're not temporizing crowns. There are lots of materials that are available in today's day and age to give extremely aesthetic and extremely sound temporary crowns. So ensure that you're doing that. And then, of course, the ferrule that everybody talks about. You need to have 1.5 to 2 mm of sound tooth structure onto which your restoration is sitting. So this is a case that we had completed in the clinic a few months back. And we've tried to ensure here that we don't skip any of the steps that we just discussed. So it's about 3-4 months now since we gave him his final prosthesis. So this is how we started off, the images on the left side. And on the right side, this is how we finished. If you see, after we've given, you can still see the stippling in his gingiva. It's a healthy gingiva. And the images on the right are during the process of the gingivectomy that we did. Here, what we've done, like I said, an internal bevel incision. We've raised a flap. We've trimmed off the excess soft tissue that was there. We have done an osseous recontouring to ensure that we have 3 millimeters from the crest, from the alveolar bone to where our prosthesis margin is going to sit. So he should be coming in for a 6-month follow-up very soon. And I'll definitely be sharing the follow-up images in what I would assume would be part 2 of this series here. And now to wrap up very quickly, if there is one takeaway that I want all of you to take from this very short session that we've had, is that I would be thrilled if all of you here would make sure that your clinical practice has at least one Perio probe. Let's start from there, and then we'll take it stepwise. Buy a Perio probe. Anyway, this is where I practice. This is now my clinic, and this is where you will find me more often than not. Now, if anyone has any queries, I think if we can open the platform to share questions, and I'd be happy to answer any queries.
Thank you, Doctor. That was a wonderful and excellent presentation. We'll now begin the Q&A session. And please post your questions in the chat box as well as in the Q&A box. It has been enabled. We'll address as many as possible. And we'll give a break of 5 minutes, 10 minutes, and we can begin the Q&A segment. Please fill out the feedback form. The link of that has been shared already. It will be really helpful to us. And that's it. Doctor, a question coming in. How would you manage a patient with chronic inflammation who's coming repeatedly with a well-fitting crown?
Okay. Now, like I mentioned, a well-fitted crown is not essentially a crown that has not violated biological width. Okay. Chronic inflammation, the first step, of course, is to ensure that there is no local factor, whether be it calculus, be it plaque, be it residual cement. First step is always to ensure that all that is out. Um, a well-fitted crown, again, now we need to see where the margin is. We need to see where the crest of the bone is. One thing, okay, a very quick clinical tip maybe. This is something that one of my professors taught me in college. If the patient's not open to anesthesia as for a diagnostic test, if the patient's not open to getting anesthetized, a very quick measurement that you can make is using a 2D IOPA or whatever you have in the clinic with a 2D image. Make a measurement from the crest of the bone to the contact point that is there. If the measurement is between 5 and 7 millimeters, you should be safe. If the gap is more than 7 millimeters, you're going to see a black triangle over a period of time. If you see a measurement that is less than 5 millimeters, you will be seeing a situation where, like you mentioned, you are seeing a chronic inflammation and you see either swollen papilla or bleeding gums. If, in spite of having removed all local factors, you're seeing that a well-fitted crown is still having a lot of inflammation around it, it is almost exclusively because of your gingival width in encroachment. If changing the crown is not an option, raise a flap, open it, your internal bevel gingivectomy, you raise a flap, trim off, see where the alveolar crest is. establish a 3 millimeter gap between the crest of the bone and the margin of your restoration, and you should be fine.
Uh,
I hope that
okay.
answered the question.
Yes, doctor. So there are certain cases in which the lab keeps requesting deeper margins for aesthetics for retention, especially in the
Correct.
interproximal areas. How do you avoid
Right.
unintentional biological width invasion and also keep correcting that at the same time?
Here, like I mentioned, planning your processes before you cannot have your tooth prepped and then you cannot reach out to the lab and say, and you cannot have the lab complain. It cannot be that back and forth. You should be planning your prosthetic margins way before you go ahead and give crowns. Another very simple way to do it is start temporizing your anterior crowns. Even if the anterior temporaries have to be there for a little longer, you can eliminate all these problems that come in, because now with how your anterior, your aesthetic restorations are, once they're cemented, definitively to get them off is not easy. So I would say, if the patient, of course, if there's no time constraint involved, I would say make sure that you're giving a temporary first, see how the soft tissue around it is adapting. Once you have a well adapted, a well healed soft tissue, go ahead and place your definitive crowns. Don't rush your definitive crowns. Like you mentioned, deep margins are there. So it could be because of caries, it could be because of a fractured tooth that you have to compensate, and your margins are going slightly deeper. So in these cases, make sure that you're planning a little bit before you go ahead and get started with delivering treatment.
Okay. What's the healing period after laser assisted crown lengthening?
Um, so now the laser might be a bloodless procedure when you're doing it, or a minimally bloodless procedure. But what is happening here is your soft tissue is going to take around the same amount of time to heal anyway. So the ideal way to do it is, see, now if you're using a laser, you are not going to be trimming off any bone. So if you're lucky, in about 2 weeks, 3 weeks, if you go ahead and give your final crown, you should be okay. Just following a laser, if you're doing it with a scalpel, I would say give it maybe another week.
So, if we are planning multiple crowns or we are planning a bridge, and we know that the patient is periodontically compromised, so how soon after crown placements do biological width violations typically become clinically evident? That's the question.
How quickly?
And
Depending on a
how
patient. Sorry, you were
what
asking how quickly, right?
how
Like the
quickly and
amount of
what
time.
yeah, and what are the signs, clinically evident signs which we should start seeing and the time
Hmm.
frame?
Yeah. So your body here now, it depends on an individual's immune response. Now, in more cases than not, in about within a month, you will start seeing signs of inflammation. You will start seeing puffy gums straight within a month. If you have, again, now in a periodontally compromised individual, if you're giving crowns, we are skipping steps. So I'm going to assume that the infection has already been corrected, and we are dealing with a fairly healthy and fairly stable gingival or periodontal situation. So, based on that assumption, if we have violated biological width, it is going to be extremely evident within a month. And within 3 months, you will have situations. There might, if it's a single crown, there might be cases where the gingiva pushes the crown up and all of these things. But within a month, you will start seeing signs of chronic inflammation.
We'll wait for some more questions, doctor.
Sure, doctor. Sure.
We'll wrap the session for today. Thank you so much, Doctor, for such a valuable and insightful session. And we thank all the participants for your time and engagement today. We truly hope this webinar added some practical clinical value to your everyday practice. Now, before we close, I kindly request you all to please fill out the feedback form and to stay updated with the upcoming dental events on Smileage Dental Education platform. All the links I have already shared in the chat box. Please do follow us. And in case you have any more questions, please put it in the Q&A segment right now, or you can also separately message us on the Smileage Dental community, and we'll get back to you. The doctor will answer all those questions one by one.
Sounds great.
Thank you, doctor.
Thank you. Good night.
Good night.